And it's my pleasure tonight to introduce you to Dr. Michael Kitchell, who until a year ago was practicing neurology at McFarland Clinic. Now he's retired. But before he retired, he became fairly well known in the community as an author of articles appearing in the Des Moines Register and the Ames Tribune about health care policy. He has presented a program at OLLI, the Adult Learning Program, about health care and public policy. And he's probably appeared at a number of civic and service groups throughout the area talking on that subject. So there's a lot to learn about and a lot to be told, so I'm not going to talk anymore. Take it away, Dr. Kitchell.
Okay, so I'm going to talk about four main issues tonight. First is the potential loss of Medicaid coverage. That's an access issue for a lot of Americans and Iowans. The other access issue is the high cost of health care, and that's what I told you. You may be shocked with some of these numbers. Then I'll be talking about health care quality, and that's all good news. It's going to depend upon the delivery of care. It should be patient-centered, and it should be coordinated care. And that's not the way it is all over the United States. And then I'm going to talk about healthcare value. And I'm not talking about value meaning you got a bigger box and there's more in that box. It's what's in that box that's important. It's what's of value. It's not the volume. It's not the number of the services or treatments or surgeries. It's were they the right ones? And so I'll be talking about that too, and talking about when you lower the cost, but you raise the quality, you're increasing value. And that's what I'm talking about. Higher quality, lower costs. Okay, so 34 million Americans have individual policies. That is, they didn't get it from their employer, they don't get it from Medicare, they didn't get it from Medicaid. Only 4%, only 12 million Americans have individual policies. And then Obamacare, which, as you know, started in 2010, there were 50 million Americans without insurance. And so since that time, 22 million Americans have a private insurance policy, not a Medicaid policy, a private insurance policy, which was helped to be paid for by Obamacare. And then I'll be talking about employer-based coverage, which covers the majority of Americans. But as you know, there are deductibles, co-pays, and out-of-pocket costs. Medicare covers 65 million Americans, and obviously most of us are covered by Medicare here. 79 million Americans, maybe even 80 million Americans are covered by Medicaid. And as I said, Obamacare came into effect in 2010, and Obamacare did two things. It gave subsidies for people to buy private insurance, and it added an expansion of Medicaid so that lower income Americans got more coverage by Medicaid. So that's what I'm talking about. Expanded or expansion Medicaid, okay? And that actually was 24 million Americans, and that's about the same number that are covered by expansion of Medicaid. And then unfortunately, there's still 26 million Americans who have no insurance. Some of those just don't buy insurance or don't care to get it. And they're the ones that go to the hospital, and if the hospital determines they've got an emergency condition, the hospital has to treat them. So uninsured people have to be treated unless they don't have an emergency. George W. Bush, who actually started some of these health centers around the country that cared for uninsured Americans, and they have a sliding scale for those, but George W. Bush, before Obamacare, he was quoted as saying, well, hey, there's no problem with these 50 million Americans. They can just go to the emergency department and be treated. And of course, that was what a lot of people did when they had no insurance. But they didn't get their preventive care, and it's pretty expensive going to the emergency department for various things. Okay, so most of us, like I say, are covered by Medicare, is 65 million. I think you know there's a Part A, which is the hospital part, and that's free. Part B is the outpatient as well as the doctor services, and it starts off at $185 a month, and it goes up for people who are wealthier. Then Part C is not really well known because it's just basically called Medicare Advantage. And so in Iowa, about 35% of Iowans choose Medicare Advantage. That's private insurance. It's a little bit of a managed care type of situation, so you're limited in the number of doctors who are on your panel. If you go out of network, you have to pay more. But if you go to a covered doctor and a covered hospital, Medicare Advantage will usually pay, although you've heard about these managed care companies denying and delaying care. And I think you know that that assassination of the United Healthcare executive was basically because of those concerns. And then Part D, I was actually present when the press conference was announced in Washington, D.C. in 2003. And that was the first time that drugs were covered by Medicare. But as you know, it's not run by the public Medicare. It's run by insurance companies who will give you a package. So you can either buy an average Part D program for about $45, $46 a month, or you can buy a cheaper one, but then you have to pay more if you get second half to have the expensive drug. So there's a choice, though, of the Part D. Now, Medicaid covers more people, 79 million right now, and that includes those 24 million that I said were the expansion Medicaid patients. And those are basically 19 to 64-year-old men, more men than women, because a lot of women who have children would be covered by Medicaid if they had low income. But the low income men were not covered by Medicaid until Obamacare had the expansion. But that's important. When I talk about the Medicare expansion, I'm talking about mostly 19 to 64-year-old low-income men. The traditional Medicaid patients, which started in 1965, that includes the elderly patients, like those of us who didn't have enough income to buy Medicare. Medicaid covers the elderly. And it pays for nursing home coverage. 1/2 of American nursing home residents are covered by Medicaid. And believe it or not, that number in the nursing homes is actually double that number that get Medicaid services either in the home or in the community. So again, half the patients in nursing homes are covered by Medicaid, the rest are private pay. And those patients who have community and home services by Medicaid are actually double the number in nursing homes. But if you had your choice, I presume everybody in this room would rather be at home and get home services rather than be in a nursing home. I don't want to tell you how expensive a nursing home is, but many of you know that it's extremely expensive. Okay, so again, the Obamacare Medicaid expansion covered 24 million low-income adults, mostly men. And as I said, in Iowa, that Medicaid expansion is called Iowa Health and Wellness Program, IWAP. And it's 182,000 Iowans. And these are the folks that are at risk. This is the threat that I was talking to you about. Because if Medicaid is cut, this is who's going to lose a lot of their services. You have to have an income that is about 130 to 138% of the poverty level. In other words, if you're a single man, low income, you'd have to have an income that's about $20,000 or less to be on this program. Now, Iowa surprisingly did agree to having Medicaid expansion. It's mostly blue states. About 10 red states like Texas, Florida, the South, they did not add Medicaid expansion. And in Texas, 23% of Texans have no insurance. So if you're a hospital administrator in Texas, you're saying, who's going to pay for all these uninsured patients who come to our hospitals? Now, going back though, Medicaid expansion was welcomed by Iowa and some other states and governors because Obamacare paid 90% federal money and 10% state money. So it's a bargain for Iowa to say, well, let's cover these 182,000 Iowans because we're only paying 10% of what it costs, and the federal government is paying 90%. And half of the states, like I say, Texas doesn't do that. Florida doesn't do it. So half of the states, though, have a blend of 90% federal money, and the traditional Medicaid patients, which are the elderly, the disabled, those are the traditional Medicaid patients, the blind patients, they are covered. And that is actually paid for traditionally since the beginning of the Medicaid program. It was covered by 1/3 state taxes and 2/3 federal taxes. So again, the federal money is much greater for the expansion patients. So everybody understand that? Okay. So this is the first part that I'm going to talk about, the potential loss of access to Medicaid. And if you don't know, the House budget has two committees, Energy and Commerce Committee and Ways and Means Committee. And they both came out with a little different proposal on how to deal with this. Because the Republican budget over the next 10 years actually plans to cut a total of $880 billion over that 10 years. And they're going to take it mostly out of Medicaid. Hopefully they won't take it out of Medicare. But I'm going to talk more about what the potential is for those cuts to Medicaid. So there are two parties that are going to be affected by these Medicaid cuts. There are the patients. These are why the Iowa legislature passed a law saying that those Medicaid expansion patients are going to have to show that they're actually working 20 hours a week or more, okay? And if they don't show that they're working 20 hours a week or more, you're no longer covered. So that threat to the beneficiaries is basically to those Medicaid expansion patients. And I'll talk a little bit more about that. But there's another effect here that the hospitals in the United States are very concerned, and they're sending lots of lobbyists and lots of hospital personnel to Washington to beg the politicians not to cut Medicaid. And why is that? Because when those uninsured patients, those newly uninsured patients go to the emergency department, they have to be treated unless they're not that sick. So the hospital gets $0 for those 182,000 Iowans who might lose that Medicaid coverage. Now, fortunately, both House Ways and Means and Energy and Commerce committees, both of them don't completely get rid of the Medicaid expansion patients. But I'll go into those details if you want those later. But there is also a second enhancement for hospitals that has been going on for 2 years here in Iowa that actually helped the hospitals in Iowa pay for the Medicaid patients, and that could go away too. So there are two ways that the hospitals in Iowa may get affected by these Medicaid cuts. Now, these are the arguments that I hear from the politicians. This is not what I think. This is what the politicians are saying, okay? These low-income Americans are often men in the working age, and they are able-bodied. Well, yeah, they're not disabled because that's the traditional Medicaid. And then the other argument is welfare, not health care. And welfare makes people dependent, it makes them trapped, and they get addicted by these handouts rather than teaching them the rewards of work. So they also say we should limit Medicaid only to disabled people, mothers with dependent kids, and retired low-income Americans. They don't want to cover those low-income working age people. And then another politician said, the Medicaid industrial complex is corporate welfare for the healthcare industry. But I guarantee you the hospitals are lobbying very hard on this issue. Okay, so what are the consequences? People who have the expansion Medicaid, they actually, since 2010, the people in this expansion Medicaid actually grew healthier, they were financially more secure, and the inequities in healthcare access and outcomes improved. And then those Medicaid patients who no longer have access often delay or avoid necessary medical care. And then, as I said, their only choice, since they can't go see the doctor, because the doctor, unless they want to pay out of pocket, they would go to the emergency department and then get their care. But as I'll show you later, emergency department care is approximately 10 times as expensive as seeing a doctor in the office. So hospitals cannot turn away those uninsured patients, and that can be very expensive. Okay, so does anybody know what the Medicaid budget is for the state of Iowa? It is $9 billion. And you may say, well, gosh, that sounds like a lot, but you know, how much does Iowa State get from the state of Iowa? What's the budget for Iowa State University? It's about $200 million. 200 million as opposed to the Medicaid budget of $9 billion. That's about 45 times greater than what is sent to Iowa State. Now, Iowa State gets money from tuition. Iowa State gets about $500 million in research grants. So don't worry, Iowa State is not going broke. But I just want to tell you what the staggering amount is that our state is paying. And as I said, if you mix that 90% and 10% with the 2/3 and 1/3, you'll see that the amount of money coming for Medicaid from the federal government is 76% of that. It's 6.8 million, as opposed to 2.2, billion. And it's opposed to 2.2 billion from the state taxes. So the state of Iowa is not paying very much for Medicaid. The federal government is paying the most of that. So as I said, there are 182,000 in that Medicaid expansion, and there are about 520,000 Iowans that are covered by traditional Medicaid. As I said, those are the disabled patients, the blind patients, the patients who, it's usually mothers with dependent children or pregnant women who are part of that traditional Medicaid program. So what does that Medicaid $9 billion pay for? And you can see that the majority of this goes to nursing home care, 25%. And then about 18% pays for that home or community services, even though there are twice as many patients in that home care program. And then only 15% goes to hospitals, 10% goes to physician services. In fact, if you look at primary care doctors, they get 4% of the money that Medicaid pays. And then prescription drugs are about 8%. And then mental health is down there in the other category too, so I don't know exactly how much that is. Okay, so what are the national numbers? 48%, virtually half of American children are covered by Medicaid or the CHIP program, Children's Health Insurance Program. So we have wealthy people who have kids, but half of Americans' kids are covered by Medicaid. And then if you look at the births in the United States, 41% are to these low-income women who are covered by Medicaid. And we should be grateful that they are covered by Medicaid so they can get good prenatal care, because if women don't have good prenatal care, bad things happen. And that's where I want to talk about disabled people. These people on disability, someone who had a stroke and was disabled, or someone who had cerebral palsy and was disabled. When you look at those disabled people, 17% of US children are on some type of disability. And it's usually behavioral or emotional or developmental, in other words, a low IQ. And only less than 1% of these disabled kids have some sort of mobility problems like cerebral palsy. Now, I'm just going to take a little diversion here because it's something that really struck me when I saw this. About 7.9% of Medicaid patients have been treated for substance use disorders, either methamphetamine, opioid, or other drug abuse. And in Iowa, it's actually higher than the national average. 9.4% of Medicaid patients have been treated for substance use disorders. And our vice president's home state, and you remember he wrote a book on this, Ohio has a 15.7% rate of Medicaid patients who have a substance use disorder and are treated. In New Jersey, they've said that out of 106,000 substance use disorder patients, 60% were covered by Medicaid. So you can see how Medicaid, low income, and substance use disorder go together. The good thing was from 2023 to 2024, that's before the border was closed, but from 2023 to 2024, they actually had a reduction in the opioid deaths by 24%. So those fentanyl deaths were going up, and in 2023 they started to go down. And they actually went down about 24%, and they attributed much of that improvement in people not dying of overdoses to this substance use disorder treatment. So obviously the study results were that any cuts in those Medicaid expansion patients would increase overdose deaths. So as I said, losing Medicaid coverage, those patients would lose treatment and there would be more deaths because of that. Okay, so I'm done with the Medicaid expansion now. So we're going to go on to the most shocking part of my talk tonight. So hopefully, if you have any questions, these numbers may shock you. But there are many reasons why healthcare costs are high. I'm going to talk about how it affects access. And then you may have heard that we want jobs to come back to the United States. We want to build cars in the United States. But if you know why Frigidaire left Webster City and Maytag left Newton, Iowa, you know it's because the employers, the businesses, couldn't afford the costs of the wages and the benefits. The average cost of wages in this country is $30 an hour. Benefits, which are retirement and health care, those benefits are $13 an hour. So I presume you don't think that they pay workers in Mexico $30 an hour or in China $30 an hour, and I guarantee you they don't give benefits for health care either. So this myth of bringing all these jobs back to the United States, I'm afraid it's all a myth. I don't see how it's going to happen. So we're going to compare, though, the cost of health care in this country to other developed countries like Europe, like Canada. In those countries, they don't have a history of employers or businesses paying for health care. They have 70 to 85% of their health care costs, and they do sometimes, like in Great Britain, they have some supplemental coverage. But basically, the government is paying for the great majority of the health care. And in the United States, most of us were alive in 1965, but that was the first time Medicare and Medicaid began to cover Americans. So before that, the government did not play a role other than regulations. It did not pay any price for that health care. And with our aging population, this percent will grow. So this is the shocking number here. $14,400 per person, that's per man, woman, and child, is spent on U.S. health care. That was in 2023. It's about $4.95 trillion this year. And we spend double what most countries spend per person. And about, if you take out your wallet and you have $60 in your wallet, how many dollars out of that $60 is going to health care? $10 out of that $60 is going for health care. So the businesses' budgets for health care is a lot more expensive in the United States than it is in any other country. Okay, and I think you might have heard yesterday that there are 385,000 Iowans who have food insecurity. 385,000 Iowans have food insecurity. But basically, nationally, one half of families struggle to afford health care, as well as their rent and the food. And then 100 million Americans have medical debt, and it continues to be the largest cause for bankruptcies. And healthcare siphons money away from education, the environment, and housing, just like I gave you the example of what's the budget for Medicaid versus what's given to Iowa State from the state of Iowa. Okay, why is the U.S. healthcare cost so expensive? Now, I could go on for an hour or two on this, but the administrative costs are definitely part of this. About 15% of the health healthcare premium dollars actually goes to administrative costs of the insurance companies, and Obamacare limited it to 15%. And the insurance companies had to give back more if they charged more than what they paid for in healthcare. But one of the points that I really want to drive home here tonight is utilization. When doctors order a test or when doctor orders some treatment, if it's not helpful and it may harm the patient, that's what we call overutilization. So in other words, they are doing more services than are necessary because they got paid for doing that service. It's called fee for service, and I'll explain that a little bit more here. But the point I'm making is fee for service payment policies give an incentive to do more. So there's more volume, there's more utilization, there are more unnecessary surgeries done that don't need to be done. How many back surgeries did Tiger Woods have? How many back surgeries did he have? He had 6 back operations. Now, I have no idea, other than I know what the surgery he had done was, but it was back surgery, and if the first one didn't succeed, maybe he should have chosen a different surgeon, or maybe the third one, maybe he went to a better surgeon, or maybe the 4th or the 5th or the 6th one. Didn't it help him? I mean, why did he have 6 of them? But that's my example. Why do we want to incentivize more services when they may or may not be, especially if they may not be helpful, they may actually be harmful? They found that in Florida, the utilization was basically double what it was in Iowa. And of course, in Florida, they had far more complications of surgery, like an infection after surgery, or the knee replacement just didn't work very well. So again, overutilization is bad for the patient, and it's bad for everyone's pocketbook. So I'm going to give you some examples, and I want to make 2 points here, though. I want to show you how in healthcare there's a lot of cost shifting. I'm not going to give you the examples from hospitals because critical access hospitals and regular hospitals like Mary Greeley have a different payment structure. But basically, for physicians, if I saw a Medicaid patient in my office for a routine office call, Medicaid would pay me $31. If I saw a Medicare patient, I would get paid for the same service $62. And if Wellmark was actually the insurer, I'd get paid 3 times what Medicaid would pay. Now, if you were a doctor and you were in rural Iowa and half of your patients were Medicare and Medicaid, which is the average, would you see 3 Medicaid patients or 1 Wellmark patient? I think you'd probably want to see 1 Wellmark patient. So this is why rural healthcare is in sad, sad shape. They don't have enough doctors. There are half as many doctors in rural America as there are in urban America. Another example of the fee-for-service, Medicare pays $7 for a lab test, a blood test. Most clinics like McFarland Clinic would lose money by doing that test. And I guarantee you at McFarland Clinic, we lost money doing x-rays for Medicare patients because they pay $31. If you went to the hospital across the street, you'd have a payment of over $100 for those 2 chest x-rays. So I'm making 2 points here. Number 1, Medicaid and Medicare pay much less, but I'm also making a point that when doctors get paid more to do a back operation, they tend to do more back operations, and unfortunately, the ethics of the doctor make a difference.
Mike, I want to check something. So if you got the same 2 x-rays, instead of getting them at McFarland, you went over to the hospital, McFarland, or Mary Greeley was paid more. And so, is McFarland send him over to the hospital?
No, and as a matter of fact, this brings up a good point. You may have heard about the new surgery center, ambulatory surgery center. Actually, Mary Greeley is losing money now because the ambulatory surgery center is half McFarland and half Mary Greeley. But basically, an ambulatory surgery center pays much less. The insurance and Medicare and Medicaid pay much less for an ambulatory surgery event than at the hospital. Now, the reason hospitals get paid more is because they have to have the emergency department open 24 hours. They have to have people there even when there might not be some business, whereas in a doctor's office, they close at night and don't have to have all those extra services. The cost shifting that happens in all U.S. hospitals, though, is incredible because there are uninsured patients that the hospital gets zero. And there are many patients who get admitted. I was on the rehab program as the rehab director, and we couldn't discharge a patient because the nursing homes wouldn't take the patient because they got paid so little by Medicaid. So we had to keep the patient in the rehab unit at Mary Greeley for a long time until we found somebody who would take that patient. So again, hospitals have all kinds of cost shifts. So the hospital has to make more money here than there. And I can tell you at McFarland Clinic, we have a lot of rural offices like Story City, Jefferson, Iowa Falls. Those hospitals lose money, especially when you look at the x-rays or the labs. But the clinic says, well, we make some more money on well-marked patients, so we're going to keep doing what we're doing. So again, that's cost shifting. So good and bad hospitals and good and bad doctors, they cost shift. They have to find a way to pay for things that the insurers or Medicare or Medicaid doesn't pay. But again, it's a problem. I don't want to go into too much more detail on that. Now, the problem, as I said, that with this fee-for-service, those doctors in Florida, for example, when they did more and more tests and more procedures and they weren't really necessary, they drove medical spending up. The inflation of healthcare costs is about 2% higher than regular inflation. And if you compound interest at 5%, versus compound interest at 2 to 3%, which is the usual inflation, the 5% adds up pretty badly. And this is what is the share of America's healthcare costs. So private employers are actually spending more money than Medicare and Medicaid, despite the fact they have many more patients. If you look at a 20-year-old to 29-year-old, their average amount of money that insurance companies spend on them is probably about $2,000. But by the time you get into the 50 and 60-year-old ranges, then it's more like $12,000 to $15,000. So the age of the patients was how they decided on premiums in the past, but Obamacare changed all that so that everybody had to have the same premium. So an employer, if you work for an employer, if you're sick, they pay the same insurance as the patient who never gets sick. About half of the US population has less than about $200 in healthcare costs per year. Half of the population, the healthy population, has very little cost. The average Medicare patient, and I'll go into this in more detail, the average Medicare patient, those of us in this room, it's $15,800 per Medicare patient. So I'll go into that a little bit more. Okay, so this is where the money goes. If you look at Medicaid, as I said, the Medicare patients average $15,800. The Medicaid patients average $9,000 per patient. And that's a lot of disabled people too. I'm not talking about the Medicaid expansion patients. I don't know what their cost would be, but it would be low. Okay, so where does this Medicare money come from? And I think you remember when you were paying payroll taxes, there was a portion sent to Medicare. And then those of us who have to pay Medicare Part B premiums, again, the higher the income, the more you pay. And then these out-of-pocket costs that even Medicare Advantage will charge, if you take the premiums and those out-of-pocket payments, that's about 15% of that Medicare funding comes from that. Now, again, these are shocking figures, but this is why I've told you that this myth of having jobs coming back to the United States is a myth. So the average cost of an employer-based insurance coverage in the United States is $24,000 for a family of 4, and the employer pays the majority of that. That's $17,500 for one employee in the family. In California and New York City, though, those costs are basically double what they are in Iowa. And in Iowa, we have about 30% less than the average for those costs. So we're lucky that we live in one of the 3 to 4 lowest cost states for health care. So that's the good news that I'm giving you tonight. So as I said, the employer pays $17,500 and the employee pays $6,500 for their family coverage. That's the average in the nation. For a single employee, the cost is paid more by the employer, but it's still $7,000 for one employee, one single employee. For that employer has to pay that for their health care coverage. And as I said, half of all Americans, 53%, have employer-sponsored health insurance. Now, smaller employers are like McDonald's or some of these service industries that have a little better than minimum wage. Only 3% of those small businesses actually give health care benefits. But 98% of employers who have 200 or more workers give those health care benefits. Okay, I'm going to shock you with some more dollar figures again. What are the average costs for an office visit? And then what's the average cost if you slipped on the ice and banged your head and you went to the emergency department complaining of a headache after you banged your head on the ice? What would a routine hospital stay? Let's say somebody had a COVID case, but they didn't have to be on a ventilator, but they were in the hospital for 5 or 6 days. What would those costs be in an average hospital? And I took care of people who had COVID that were on ventilators and had to come to the rehab program at Mary Greeley. So I got to see people who were costing the system $500,000 for that one 3 to 5 month episode of COVID infection. Okay, so this is where healthcare economics really is important. If you see a doctor in the office and you might have a lab test or two, it's $100 to $150. Obviously, if it's New York City, it's double that. But an emergency department visit, like I say, if I hit my head and I had to have a CAT scan done, that would easily come to $1,000 to $1,500 for one emergency department visit. Now, hopefully the insurance will pay most of that, but again, that's the cost. And that routine hospital stay, again, is 10 times as expensive as the emergency department visit, 100 times more expensive than the office visit. And then if you were a COVID patient and you were in the intensive care unit for a long time, or you had an infection that started as a pneumonia and went to your bloodstream, that could cost, again, $200,000 to $500,000. And then one of those operations that Tiger Woods had, he probably had it in a high-cost state, probably $100,000 to $150,000 for each of those 6 back operations. And then if you had a stroke where you had a bleed inside the brain, that would be about $50,000 to $100,000. And as I said, if you take a look at those higher cost states like California, New York, it is way higher. And so my point is, if we had some way to prevent these illnesses, if people got vaccinated for COVID, they wouldn't be in the hospital, they wouldn't die. So these are preventive things that we need to do. So in 1965, before Medicare and Medicaid started, the gross domestic product was about 6%. The cost of healthcare was about 6% of the gross domestic product. But as I said, right now, the cost of healthcare is 17% of our gross domestic product. And back in 1965, healthcare costs were $210 per man, woman, and child. And they are $14,400 now. And that's 68 times as expensive. Now inflation went up about 10 times. So the net was about 6.8 times. So we're spending way more than we used to on healthcare. So, as I said, the blame for a lot of these healthcare costs is this fee-for-service payment model, which incentivized more volume of services, not necessarily the right service or a higher quality service. So this is the third part of my talk now, and this is about quality. Does quality make a difference? It sure does, okay? Higher healthcare quality is actually cheaper than low quality healthcare. And even though the United States excels in cancer care, biomedical innovation, transplant, and invasive surgery, our quality is actually among the lowest in the developed countries. Our life expectancy is 4 to 5 years less than these other developed countries. And the access, as I said, is not as good in our country. And health equity, for example, in rural America, rural Americans have a 23% higher death rate, and they have a 40% higher unnecessary hospitalization rate for things that could have been treated but had to be in a rural hospital. So rural health inequities are huge, and I can go on for a long time about that. But administrative costs are really the highest of any country, and that's, again, we have United Healthcare as a stock market price. If you want to look at it, it might be going up or down depending on the politicians, but that's where the United States really goes higher, is in administrative costs. So let's talk about quality, though, because we all want higher quality care. Is there anybody here who wants to go to a low quality hospital? Okay, I didn't think so. So it's the degree to which services increase the desired health outcomes for individuals and populations. Is the care safely done? If you were in Mary Greeley, what did they do to keep you from slipping and falling on your way to the bathroom? Did they prevent these falls that could have injured you? Was the care timely? Did you get your stroke treatment quickly? Did you get the right treatment for your heart attack? Was the care effective? Did the surgery that you had correct your problem? If you had shoulder surgery, did you get back to work after the shoulder operation? Was it efficient? In other words, was it relatively less costly? There are certainly choices with drugs, like generic drugs or brand name drugs. Is it efficient to use the cheaper generic drug? And is care equitable? Like I gave you the example of rural health care. It's not equitable in this country. And then, is it patient-centered? Sometimes you might go to a doctor who is provider-centered. He's gone home, it's 4 o'clock, he was done for the day. So that is what I'd call provider-centric. So you want to go to a patient-centered care. Now, scientific evidence helps to determine what is the best care, and I think you've heard some of the examples about the vaccine issues, and if we don't have scientific evidence, I just really think our country is going the wrong direction, but we need the scientific evidence to determine the best care. And if you really want to show that you've improved quality, you have to use some measurement of quality to prove that you're doing better. So how do we improve value? Cost and quality awareness changed healthcare payment, and so there's pay for value. That means quality divided by cost. So the lower the cost, the higher the value, the higher the quality, the same cost, there's higher quality because there's higher value because of higher quality. And as I said earlier, value is not volume. It's not more use of those services. It's doing the right treatment for the right diagnosis and having the right outcome. So research actually showed there was a marked variation in regional healthcare quality, costs, utilization, and outcomes. As I told you, Florida had very high utilization. Iowa had low utilization. Florida had low quality. Iowa had high quality. So value in Iowa has been a very high value of care for many years in Iowa. And the research showed that the more volume of care simply added to the chances of complications and costs. And they really estimated that about 20% of healthcare costs are due to inappropriate care. And then how care is delivered by providers makes a difference. Do the providers communicate? Does your family physician, your primary care doctor, communicate with your surgeon? Does the oncologist get back to the primary care doctor? Do they work together to make sure the right thing is done? So that's communication, that's collaboration, that's coordinated care, and integrated care. Integrated care means a team-based care led by good primary care providers with multiple providers coordinating, collaborating, and communicating. This is what is the basis for McFarland Clinic. We have what's called a multi-specialty group, so that the primary care doctors, the surgeons, the specialists work together as opposed to single specialty groups. Like there's a cardiology group here, there's an orthopedic group over here, there's an eye group over there. They don't really coordinate care that well. They are what we call single specialty or siloed groups. That is, they are in the silos as opposed to integrated and coordinating their care. And so the best care is integrated. And the focus is on prevention, promoting healthy behaviors, and getting disease management for chronic diseases like diabetes. In 2010, McFarland Clinic was starting to get paid for performance. That was part of the Obamacare law. And those pay for performance actually, the results of that showed that in McFarland Clinic, our diabetic care was exemplary. Our diabetic admission rate for patients with complications of their diabetes, our diabetic admission rate was one half the national average. Our congestive heart failure patients, the admission rate was 3/4 of the national average. For those patients who had chronic lung disease, those patients were in the hospital 3/4 as much as other patients around the country. So the focus had been on getting the right care for the right diagnosis and getting it safe, timely, efficient, and effective. Now, fragmented care is the opposite of integrated care. That's because there's one doctor over there, another group over there, another doctor over there, and they don't coordinate. They don't even share the same electronic medical record. 40% of the country has fragmented care. So we live in a place where there is very good integrated care. So I'm going to end with the last part of my talk, and that's on value-based payment reform, paying hospitals, paying doctors differently. Mary Greeley has been the recipient of the Baldrige Award for Healthcare Quality. Only one hospital in Iowa has ever received the Baldrige Award over the past 25 years. That's Mary Greeley. We're the only hospital that received that Baldrige Quality Award. That's a very prestigious award. They only reward 1 or 2 hospitals per year for that Baldrige Award. Mary Greeley has been given the designation of a magnet center of excellence for healthcare, or for nursing healthcare quality. And Mayo Clinic also has had that same designation, but Mary Greeley is one of only 12 hospitals in the country that has had both the Baldrige Award and this nursing magnet for excellence in nursing care. So again, those quality, those value awards show just what we have here. So McFarland Clinic has been measured for quality by both Wellmark and by Medicare. And we have had a perfect score in the Medicare quality payment program, 5 out of the last 6 years, a perfect score. And then with our value-based care by Wellmark, our accountable care organization at McFarland Clinic has been the top of all the groups in Iowa. We are higher value, that means quality and cost, than any other group in Iowa. That includes Unity Point, Mercy, University of Iowa, and so on. So again, those payments for performance and paying for value have been something that McFarland Clinic and Mary Greeley have benefited from. Now, it used to be when someone was in the hospital, the insurance company or the government would pay them for the days and the number of patients in the beds. So what was the incentive to get the patient out of that bed? The incentive was to keep them there. So instead, the government decided to pay for a diagnosis. So if you had a pneumonia, they would pay you $10,000. If you had an appendectomy, they got $12,000. Those are just examples. So you didn't get another $200 for every day that you were in the hospital because that just gave the wrong incentive. That gave an incentive for more volume rather than value. Now, there's a way of paying called capitation that the HMOs used to do. You recall health maintenance organizations. That's actually what we have in Iowa doing Medicaid now. Those are managed care organizations. So that makes it a little more difficult for physicians and hospitals to deal with that because, again, denials and delays in payment. But the basis, though, for our new payment system, which has been going on, like I say, since 2010, McFarland Clinic has been an accountable care organization since 2013. And you may not know it, but the clinic is being held accountable for quality and the cost of care. Not for you or you or you, but for the population. That's a group of patients. We have about 35,000 patients in Wellmark and about 16,000 patients, Medicare patients. So that cost of that care is the budget for the year. And the physicians still get paid fee for service. But if the cost of that care doesn't go up very much, then that accountable care organization is rewarded. So that is what we call shared savings. And believe it or not, 1/2 of all Americans are now covered by accountable care organizations, including anyone who's been to McFarland Clinic and you have a doctorate at McFarland Clinic, you're part of an accountable care organization. And Medicare and Medicaid have a goal that was actually set in 2020, that by 2030, all patients in Medicare and Medicaid will be covered by those ACOs, accountable care organizations. So this is my last slide, and I'm happy to take some more questions or comments. The accountable care organizations are a little bit difficult to describe, but again, it's having physicians being measured for their quality and also their cost. Not like I say for you or me, but for the population. It's called population health. So it's giving them preventive therapy, like those diabetics. Our diabetic control of our patients is in the top 8 percentile. We're ahead of 92% of other groups in our control of diabetic patients. Their hemoglobin A1C is very, very well controlled. And so the benefit to the patient is not having an amputation, not having a stroke, not having a heart attack because of their diabetes. So I hope that everyone who is being treated for their diabetes has very good care, because you can live a pretty normal life if you watch your diabetes and get your diabetic control as good as you can get it. Okay, I'm going to stop here and ask for any questions or clarifications. Yeah.
Do I need to come to the mic?
No, you're welcome.
I can repeat the question if you.
Sure, that's fine. First of all, thank you for your excellent presentation. I'm Ann Kinzel. I was actually the executive director of the Iowa Legislative Healthcare Reform Act when we got Medicaid expansion passed in Iowa. So I have a passing knowledge of this stuff. But I want to make one point and then ask you a question, Dr. Kitchell. First, I'm a little concerned when you say that employers pay for healthcare costs, because I don't believe that. People are paid a compensation package, some of which comes to them as cash in a paycheck, and the rest pays for their benefits. Every single person who works essentially pays for 100% of their benefits. Okay, so I think that's really important. These are not given to us as a gift. We earn them every day that we work. So I just want to say that. But in your talk, you mentioned a lot about how Medicaid could be decimated by decisions made by politicians. And you focused on what would happen to that population. But I have another concern that I'd like you to address, because I've also had a career as a public trauma center attorney, so I was well acquainted with Medicaid. And I think that if Medicaid is destroyed, every one of us is going to be hurt that uses a healthcare system. And I'd like you as a physician to address what you would see would happen to everyday patients if the Medicaid system was collapsed.
Right. Because as you know, that slide showed that it was the patients and then the providers. But here's what happens to the providers. Rural hospitals will close. Rural hospitals have they don't have any reserves so rural America will be in worse shape than before. And then Mary Greeley is not a taxed entity. We don't pay any taxes to Mary Greeley. But Mary Greeley would lose a lot of services that we have now that we couldn't have. I asked a question yesterday of the CEO of the Grinnell Hospital, and they were building up their OB-GYN program because they are the only OB-GYN program between Des Moines and Iowa City. And so those women in Marshalltown either come to Ames or they go to Grinnell for their OB-GYN care. Medicare. But he said if they cut Medicaid, even as little as they are apparently going to do, they're not going to cut all of that Medicaid expansion. But those are services like OB-GYN.
What about those of us who, come, let's say we suffer from some disaster and we go to the ED. What can we expect as non-Medicaid patients, how the system would be affected in the care that we get?
Well, hopefully the hospitals would still recognize that the demand for emergency department rather than office visits was going to go up, and hopefully that hospital would then dedicate more money to the emergency department. But the problem is that's 10 times more expensive than seeing people in the office. Here in Ames we have express care, we have urgent care, and hopefully you could reach your primary care doctor rather than to wait 2 weeks to be seen. But what could happen, like you say, is that, well, then your primary care doctor would be overwhelmed, and then rural America, like I say, would be abandoned. I think these rural states, I think that's why Josh Hawley, the Missouri senator, is reluctant to cut Medicaid. But yeah, we'd all be paying higher taxes because these uninsured patients would not get the preventive care that they need, and they would come to the emergency department when it's too late. Their complication or their disease has gotten worse, or these diabetic patients who didn't get their care would have more complications from their diabetes. So yeah, there's endless disasters, and this is what the hospitals are trying to convince the politicians, that you can't get around it because the hospital is not going to deny you care. I guarantee you that's not going to happen, but it'll be a longer wait wherever you are.
I recently heard that the Advantage plans actually cost the government more.
They do. They pay those plans more.
And they get, the companies get more profit.
Yes. Well, the difference between Medicare Advantage is Medicare is government run as opposed to Medicare Advantage is private. So the private insurers do get more money, yes, and they admit it, but they claim that they manage the care. But I think if you talk to doctors or hospitals, they say they manage by denying and delaying. So again, I don't want to discourage anybody from Medicare Advantage because I have friends who actually like Medicare Advantage.
I have a follow-up question. Since Medicare Advantage costs more, how did they get to use the word Medicare? Why were they allowed to use the word?
I can't really answer that, but the politicians decided over the years that they wanted to give more money to the Medicare Advantage plans because they managed the care. But as I told you, that's exactly what these accountable care organizations do. Those are hospitals and doctors that will group together and say, we will cover this population of patients. And so there's no real incentive to not do a treatment because the individual is not going to be impacted, but the population would.
All good things have to go to the end.